My name is George Kennedy. I'm a staff sonographer at the University of Colorado Hospital. I have about 10 years experience here. Thank you for joining me on this webinar for scrotal ultrasound. We have several objectives today. We're going to first identify the normal scrotal anatomy, its variants and vascular supply. I'm going to describe the indications for scrotal ultrasound, the appearance of normal and abnormal sonographic findings, and then we're going to explain the sonographic technique and protocol used to perform a scrotal ultrasound. First, the anatomy. I'm sorry, that went too far. The male reproductive system does consist of the scrotum, testes, epididymis, ductus deferens, urethra, seminal vesicles, prostate gland, bulbourethral glands, and the penis. Sperm are very temperature sensitive and do not develop at the normal body temperature, and as a result, the testes and epididymis are located outside of the body cavity in the scrotum where the temperature is lower. Here, the scrotum is an external pouch of skin. I'm sorry, this keeps going further. The scrotum is an external pouch of skin, connective tissue, and muscles. It contains the testes and is divided into two internal compartments. Externally, the scrotum is marked by an irregular ridge, the raphe, which continues posterior to the anus and anteriorly onto the surface of the penis. Seen here, the red line. There are several layers of the scrotum. First is the rugated skin. We have muscle layers, the cremasteric and dartos muscles, and then we have several fascial layers. We have the external spermatic fascia, the cremasteric fascia, and the internal spermatic fascia. The superficial fascia is a loose connective tissue, and when it's cold, the dartos muscle contracts, causing the skin to become firm and wrinkled, thus reducing the overall size of the scrotum. At that time, the cremasteric muscle, which also is an extension of the abdominal muscles, contracts, pulling the testicles near the body. When warm, they do relax and expand, allowing the testes to descend away from the body. Here we see those different layers. The upper portion of the processus vaginalis is normally obliterated. The lower portion, the tunica vaginalis, remains as a closed pouch folded around the testis. Only the posterior aspect of the testis and the site of the attachment of the testis to the epididymis is not in continuity with the tunica vaginalis. It has two components, the parietal layer, which lines the walls of the scrotum, and then there's the visceral layer that covers the testis and epididymis, as well as the spermatic cord. A couple more layers, the tunica albuginea is the tough layer that surrounds the testicle itself, and the tunica vasculosus, which is the connective tissue layer containing the blood vessels and lymphat. Here we can see our tunica vaginalis, our parietal and visceral layers, our tunica albuginea, and then the inner tunica vascularis. The separate layers are indistinguishable by ultrasound. However, you can identify the tunica vaginalis if there is fluid present. Here, this is a physiologic amount of fluid, and there are echogenic layers delineating our tunica layers. Now we'll cover the anatomy of the testicle. They are a paired, small ovoid gland that are homogeneous and a medium gray tone on ultrasound. Both the weight and size of the testicles normally decrease with age. They're approximately 3 to 5 centimeters in length, 2 to 4 centimeters width, and about 3 centimeters height. They weigh between 12.5 and 19 grams. Here we can see a normal testis on 2D ultrasound. The septula divide the testis into lobules, and arise from the tunica albuginea, the outer layer. Here, on ultrasound, they appear as linear hypoechoic or hyperechoic structures. This can be mistaken as a orchitis. You would want to add color Doppler to see if you have increased flow. If you see this without increased flow, normal anatomy. Here we have some more images showing the septula testis, here converging at the mediastinum. Now the seminiferous tubules. This is where sperm is produced. It also matures and is transported through the seminiferous tubules. There are hundreds of tubules contained with each testicular lobule, and combined together it equals nearly 1.5 miles. They do course centrally, forming 20 to 30 larger ducts, termed the tubuli recti. The tubuli recti enter the mediastinum to form the reedy testes. Here we can see the reedy testes are seminiferous tubules located within the lobules, converging to make our efferent ductules, which is about 10 to 15 ducts that exit the mediastinum to form the ductus epididymis. The mediastinum is the posterior convergence of the tunica albuginea, seen here on ultrasound as a linear echogenic band running longitudinal. It does provide support for the entering and exiting vessels and ducts. Now the epididymis. It's a curved structure measuring approximately 6 to 7 centimeters. It usually lies posterior and lateral to the testis. It is composed of a head, body, and tail. Starting with the head, it's also termed the globulus major. It is the largest portion, measuring between 10 to 12 millimeters in an AP dimension, anterior to posterior. It lies adjacent to the superior pole of the testis. And again, this is formed by that efferent ductule of the reedy testes. The body lies adjacent to the testis, seen here. It's formed by the ductus epididymis, which is about 60 centimeters long. The ductus epididymis itself is a convoluted duct that is here throughout. The globulus minor is the tail, loosely attached to the lower pole of the testis. Final maturation of sperm does occur within the epididymal tail. The ductus epididymis does form an acute angle at the distal aspect here. It makes an acute angle and heads back up the spermatic cord. Here on ultrasound, the epididymis appears isoechoic or slightly echogenic to the testicle. It does have a coarse echo texture. And here at the University of Colorado, any measurement less than 10 millimeters in an AP dimension is considered normal. Here you can see the body of the epididymis lying posterior to the testicle. In this image here, we see a little bit of the head, body, and tail of the epididymis. Testicle is out of plane. The vas deferens, or ductus deferens, transport the sperm from the epididymis to the ejaculatory ducts. Once they emerge from the tail of the epididymis, they ascend along the posterior side, medial to the epididymis, and become associated with the blood vessels and nerves that supply the testicle. The walls are composed of smooth muscle for ejaculation to move the sperm. A vasectomy is a surgical male contraception. They cut the vas or block it. More about the spermatic cord. It is composed of these different anatomy, the vas deferens, the cremasteric, differential, and testicular arteries, the pampiniform plexus, lymph vessels, nerves, and fascial and muscle layers. Here is the spermatic cord cut open so we can see the contents. On ultrasound, the intra-abdominal portion of the spermatic cord appears as an echogenic round structure. This may be difficult to distinguish from surrounding tissue. Here in the longitudinal, you can see scrotum with testis and the spermatic cord. The seminal vesicles are a paired pouch-like gland, approximately 5 centimeters long. You join the vas deferens to form the ejaculatory duct here at the base of the prostate. Our vas deferens coursing, meeting with the seminal vesicles to form the ejaculatory duct. They do lie obliquely and caudally to the prostate, and they secrete about 60% of the seminal fluid. Here on ultrasound, you can see they are curvilinear, hypoechoic structure. It may contain low-level echoes, which would be the fluid that it secretes. Here you can see either the ejaculatory ducts that will then join with the seminal vesicles. The arterial supply. The differential cremasteric arteries supply the epididymis and extratesticular tissue. Then we have our testicular artery that supplies the tunica vasculosa, central pedal branches that then course within the septula, and then the recurrent rami, which course within the parenchyma of the testis. You can see here within the spermatic cord, our testicular artery comes down to feed, while the rest, the cremasteric and differential, feed the epididymis. Normal capsular and intratesticular arteries show a low vascular resistant waveform seen here on our left with an RI of about 60%. Extratesticular arterial supply do have a high impedance waveform, so you would have less diastolic, a higher peak systolic, and a much higher resistive index. The pampiniform plexus, which drains the testicle. The testis and the anterior epididymis drain into the anterior pampiniform plexus. Then there's the posterior epididymis and vas deferens drain into the cremasteric and differential veins. It is a small network of veins within the spermatic cord. You can see both the anterior and posterior plexuses. The right testis vein does drain into the vena cava. You can see here. The left testis vein drains into, this is the right draining into the vena cava, and then our left draining into the left renal vein. Because of this normal anatomy, it does cause a congestion due to this location of the left renal vein. So left-sided varicoceles are rather common. Now some normal variants that we see on scrotal ultrasound: appendix testis and appendix epididymis, also known as hydatid of Morgagni. You can also get perididymis and vas aberrans of Haller. We can see our labeled image here. This is our epididymis. If it's coming off of the epididymis, it will be an appendix epididymis. Vice versa, if it's coming off the testis, then we'll term it the testis appendix. The asterisks here show an inferior and superior vas aberrans of Haller, which is a remnant of the mesonephric duct. And then here is the paramesonephric duct. On ultrasound, this is the testis an appendix testis. We see a testicle here with a structure hanging off the superior aspect. Pretty classic appearance. Abnormal variants, cryptorchidism. This is where one or both testicles do not descend into the normal position in the scrotum. This is the most common male infant GU anomaly. There is an increased risk with prematurity. About 30% of premature males do experience cryptorchidism. The testicle can be located anywhere along its descent. Normally, we should see the testicles within the scrotum by 36 weeks gestational age. Complete descent is needed for normal development of that testicle. Some complications of cryptorchidism: infertility. This is due to the pathological changes from the undescended testis. And then there is an increased risk for malignancy, seminoma being the most common. This can also occur within the non-cryptorchid testi as well. Sonographic appearance: they are often small and hypoechoic to your contralateral, hopefully normal descended testicle. Here we can see an undescended testicle within the inguinal canal, multiple hypoechoic masses within it. Not a good sign. Polyorchidism. This is a rare congenital anomaly. It's the presence of more than 2 histologically proven testes. 3 is going to be your most common, and actually up to 5 have been reported. The cause is really unknown. Some hypotheses is duplication or division of the genital ridge in the embryological period. You will usually find polyorchidism on the left side. Some associated anomalies you might find are a maldescent of the testicular mass, inguinal hernia, torsion, hydrocele, and amazingly infertility. Another variant that you could come across while scanning the scrotum is a testicular prosthesis, usually due to a testicular cancer. The gentleman would like the appearance of normal testicles. A silicone shell filled with saline is inserted into the hemiscrotum to replace that missing testicle. By ultrasound, you're going to see an anechoic structure with posterior enhancement. Now we'll go over some functions and physiology of the testicle. Before puberty, the testes remain unchanged from their initial development. The seminiferous tubules do not have a lumen yet, and there are few interstitial cells. Around puberty, so 12 to 14 years old, these interstitial cells do increase in number and size, and the lumen develops within the seminiferous tubules. The testicle, of course, produces sperm from the germ cells. It is a process of meiosis, where you end with 23 chromosomes. The hormones produced by the testicle are responsible of the Sertoli and Leydig cells. These cells do join together to form the blood-testis barrier, which isolates the sperm cells from the immune system. This is necessary because the sperm forms surface antigens that could stimulate an immune system response, resulting in destruction of the sperm. The epididymis function is to store sperm for it to mature. The vas deferens, like we said earlier, job is to transport the sperm from the epididymis to the ejaculatory ducts. And then the seminal vesicles, of course, produce the seminal fluid. Semen is a composite of spermatozoa and secretions of the male reproductive glands. The seminal vesicles, like I said earlier, produce about 60% of the fluid. The prostate produces 30%. The testes produce about 5%. And then the bulbourethral glands produce about 5% as well. These mucinous secretions prior to ejaculation are to lubricate and reduce the acidity in the vagina and urethra. The seminal vesicle secretions contain protein and enzymes that provide nutrients and energy for the sperm. Two gonadotropins are secreted from the adenohypophysis, FSH and LH, and although named for their functions in females, they also have important functions in males. The FSH binds primarily to the Sertoli cells in the seminiferous tubules and promotes spermatogenesis. The LH binds to the cells of Leydig in the testes and causes cells to increase their rate of testosterone synthesis and secretion. Testosterone has a major influence on many tissues in the body. It plays an essential role in the embryonic development of reproductive structures and in the development of reproductive structures and secondary sex characteristics during puberty. Okay, we're done with anatomy and physiology. We're going to go over now indications for a scrotal ultrasound. There are several I've listed here. Pain, an enlargement of the testis or scrotum, a palpable mass within the scrotum, to search for an undescended testicle in a crypt orchid patient, follow up some previous abnormality, trauma, and male infertility. Diagnostic ultrasound is the most common imaging technique used to supplement the physical exam of the scrotum and is an accurate means of evaluating many scrotal diseases. Technical advancements in high-resolution, real-time, and color flow Doppler sonography have led to an increase in the clinical application of scrotal sonography. Patient preparation, we will have them undress from the waist down. The transducer selection will vary. Typically, you're going to use a high-frequency linear transducer. You can see in this scrotum here, we had to use a curved linear structure because of massive scrotal edema. The lower frequency was needed in order to penetrate. Patient positioning, we're going to have the patient be examined in the supine position. The scrotum is elevated and the penis is placed on the patient's abdomen and covered with a towel. It is helpful for the patient to localize a palpable nodule within the scrotum. Here is a longitudinal image of a testis. Image optimization, we're going to see a medium gray tone. We want a large focal zone, a high dynamic range, and low flow Doppler settings. We're going to begin in a transverse dimension, first documenting a midline scrotum. We do this to compare the testicles to each other. You're going to want to look at their grayscale appearance and Doppler flow. After you've compared the testicles to each other, you're going to scan transverse in a superior to inferior fashion, usually starting with the unaffected testis. After you scan top to bottom in transverse, you'll then turn longitudinal and image the testicle lateral to medial. After you've evaluated the testicle, you want to image the epididymis as well, documenting the head, body, and tail. You also want to compare the epididymal color Doppler flow to the testis to determine whether it's hyperemic. We're going to document pulse wave Doppler, arterial, and venous flow within the testicle itself. This is specifically important for venous flow to rule out torsion. We're also going to measure any abnormality that we see in two planes. We will then repeat this for the unaffected testis. The measurements that we do, this is going to be of the epididymis. Here is an AP measurement of the epididymal head. Because of the epididymis being a curved structure, if you were to flatten this out, this is why this dimension would be AP, anterior to posterior, instead of here. Here, longitudinally, we're going to measure our longest distance. That will be our width, and then the height of the testis itself. Here, the epididymal body. This makes a little more sense for the AP dimension. That's the body. And then our tail. Again, an AP dimension. We want this to measure less than 10 millimeters at our facility. Other radiologists might use different criteria for size. Color, power, and pulse Doppler. Again, we'll evaluate the flow in the normal and pathological states. We do compare and document flow in each testis and epididymis. Again, we're wanting to use a low pulse repetition frequency, a low wall filter with a high persistence. These settings will just help optimize best for this low flow state. Here you can see we have a triplex image here, our color and 2D image showing normal blood flow within the testis with a pulsed wave sample measuring a 60% RI, 0.57, which is within normal limits. Benign conditions we will cover now. First is a hydrocele. It's an abnormal accumulation of fluid between the layers of the tunica vaginalis. There's a congenital and an idiopathic type. Hydroceles are usually due to an epididymitis or an orchitis, some sort of inflammation. They can also be seen in spermatic cord torsion or trauma. And a hydrocele is going to be your most common cause for painless swelling. A hydrocele is basically a defective absorption of serous fluid that's secreted by the tunica vaginalis. The congenital type results from an incomplete closure of the processus vaginalis with a persistent open communication between the scrotal sac and peritoneum. The acquired, or idiopathic, are caused by the epididymitis or other ones that I covered. A normal scrotum does contain a few milliliters of serous fluid. Here we can see a large anechoic fluid collection within the left hemiscrotum. We have a right testicle here, our left testicle here. An easy way to tell that this is a hydrocele is that it is displacing the testicle. So it's being displaced to the posterior aspect of the scrotum and is space occupying. Characteristically, they are anechoic with through transmission. They can contain low-level echoes, which is usually a fibrin or cholesterol crystal. The fluid collection is confined to the anterior lateral portion of the scrotum because of that attachment of the testis and epididymis to the scrotal wall posteriorly. Hematoceles, it's blood within the scrotal sac. Most common cause is going to be post-trauma, surgery, possibly due to a neoplasm or torsion. These are less common than a simple hydrocele. A piocele you might also come across, which is pus within the scrotum. Causes could be rupture of an abscess in an existing hydrocele. Both of these do contain internal septations and loculations. You'll use your patient history to help you determine. Here on the left, we have a hematocele, and on the right is a piocele. So you can see how they're very similar in appearance, and you'll have to use the clinical signs to decide which one. Epididymitis, it's an inflammation of the epididymis. This is the most common cause of acute scrotal pain in post-pubertal men, approximately 75%. These usually result from a lower UTI or an STD in young men. Clinical findings would be fever, dysuria. They may also have a urethral discharge. On ultrasound, you're going to see an enlarged epididymis. Initially the tail. I'm sorry, let me go back. Here we go. So testis and epididymis. We can see an enlarged epididymal tail, thickened scrotal skin, a decreased echogenicity with a heterogeneous and coarse echo texture. Not nice and smooth like the testicle is. It may have an associated hydrocele, and it should have increased Doppler flow in the affected region. Seen here, color Doppler flow, we have the testis, our enlarged epididymal tail with increased color Doppler flow, our thickened scrotal skin, and if we moved our color box up, I bet we would have increased flow within the wall as well. This was supposed to be a video, but I believe it's not going to play. No, I'm sorry, it won't. Here we can see an epididymal head that is enlarged. We don't have calipers here, but I'm guessing that's greater than 10 millimeters. We also have increased flow that's asymmetric to the testis here, which would lead us to epididymitis. Orchitis, it's inflammation of the testis itself. There's both diffuse and focal types. This is termed epididymal orchitis about 20% of the time when it involves the epididymis as well. Direct extension of epididymal inflammation to the testicle occurs about 20% of patients with acute epididymitis. You'll see color Doppler flow increased in this area. By ultrasound, you're going to see hypoechoic bands with increased color Doppler flow. So when I was going over the anatomy earlier, the septula can look very similar to this. So again, you're going to want to use your color Doppler to help you decide between orchitis or normal anatomy. Here you can see the hypoechoic area adjacent to the epididymis with increased flow. Another cine that does not work. I'm sorry, guys. Here we see the epididymal orchitis. We see a increase in color Doppler flow throughout the testicle itself. We have a thickened scrotal wall, an enlarged and hyperemic epididymis. Spermatic cord torsion now. The spermatic cord becomes twisted and cuts off the blood supply. This is more common in boys than men, and a prompt diagnosis is necessary and most often requires immediate surgery. You can have acute or chronic spermatic cord torsion. The prompt diagnosis is necessary because the salvage rate is between 80 to 100% if surgery is performed within 5 to 6 hours of the onset of pain. It is reduced to about 70% if performed within 6 to 12 hours, and drastically reduces to 20% if delayed more than 12 hours. The acute type, the patient's going to present with scrotal pain, possible nausea and vomiting. Initially, the testis becomes enlarged with the normal echogenicity and later becomes heterogeneous and hypoechoic compared to the contralateral normal testis. The sonographic findings are varied and nonspecific. We're going to have usually an enlarged testis and epididymal head with the decreased echogenicity because of the lack of blood flow. And then absent or significantly less blood flow than the normal side is indicative of a torsion. A torsion knot can change the position of the long axis of the testis. So while you're scanning and the testicle doesn't lie in its normal plane, try to find the torsion knot. Color Doppler is most useful and most rapid technique to establish the diagnosis of testicular torsion. If you are scanning a pediatric patient, it may be difficult to document flow within the normal testis because of that prepubertal state. Here we can see a normal right testis and a longitudinal axis, normal color Doppler flow. Here we have a left testis, it's hypoechoic, heterogeneous. We have no intratesticular flow. We have extratesticular flow, which you will commonly see. We do have appropriate color Doppler settings. We have a low PRF. You can't see the other parameters, but we have a low wall filter as well. Here are some more images of testicular torsion. In testicular torsion, color Doppler sonography has a sensitivity of 80 to 98% and a specificity of 97 to 100% with an accuracy rate of 97%. So you can see how highly accurate ultrasound is in diagnosing testicular torsion. Here again, we see a hypoechoic testicle. We are using power Doppler now. We have low flow settings showing absolutely no flow within the testicle or surrounding tissue. Here on the right image, again using power Doppler, we show no flow within the testicle itself. Increased paratesticular flow. Here, pulse wave Doppler. We have a heterogeneous testicle. This is basically noise. It might be a small component of venous flow, but no major flow within the testicle itself. And then showing no pulse wave spectral Doppler flow at all in this right testicle. Here is the torsion knot on ultrasound. It looks like a twisted appearance. Here on pathology, you can see why that would change the position of the testicle. It has to rotate around 540 degrees to be considered a complete torsion. We have chronic or a subacute. This is obviously less serious than acute. It can also be termed ITT, intermittent testicular torsion. On ultrasound, you're going to see a small heterogeneous testicle. This is due to a long-standing blood flow deficiency. The tunica albuginea will be thickened. You might see an irregular or thick epididymis. At times, you will see no Doppler flow within the testis, but at other times, because it is intermittent, you might find flow. And then again, you'll have increased color Doppler flow within that paratesticular tissue. That's because of our different arterial supplies. Again, the testicular artery is supplying the testicle itself, whereas the cremasteric is supplying the paratesticular tissue and the epididymis. So it has a different blood supply. Partial torsion is where the testicle rotates 360 degrees or less. The arterial flow may still occur. You'll probably have a higher resistive index, so above 70%. It would also be asymmetric to your normal testis, the resistive index. The venous flow is often obstructed, but not always because of the rotation only being 360 degrees or less. But you should see diminished diastolic arterial flow on spectral Doppler. Symptoms of acute torsion. With partial torsion, the patient will have symptoms of acute torsion, but followed by spontaneous detorsion and regression of symptoms. If spontaneous detorsion occurs within the affected testis, it may appear normal, or it could also mimic orchitis. Here we can see a partial torsion with a reversed end diastolic flow. Here, this is normal, antegrade systolic flow, and then here's our reverse diastolic flow. We have a heterogeneous hypoechoic testicle, not much flow within the parenchyma itself. Again, we have increased paratesticular flow. We have a small little arterial vessel here with the abnormal RI. You should always compare to your contralateral side, which is hopefully normal. There's a couple different types of torsion. Our most common is intravaginal torsion. An anomalous suspension of the testis by a long stalk of the spermatic cord results in a complete investment of the testis and epididymis by the tunica vaginalis. This type of torsion frequently occurs during puberty, and this is termed the bell clapper deformity. Approximately 50 to 80% of these bell clapper deformities are bilateral. Intravaginal torsion is also common in an undescended testis after orchipexy. Extravaginal torsion, it's a rotation of the epididymis, testis, and tunica vaginalis as a unit and causes the rotation of the spermatic cord at the level of the inguinal ring. This occurs most often in newborns without the bell clapper deformity. Thus, the tunica vaginalis is normal. Here we can see the diagram showing A, our extravaginal torsion, where the twisting occurs at the inguinal ring. We have a normal tunica vaginalis. B, our intravaginal. We have a abnormal tunica vaginalis. You can see why it's called a bell clapper. You can see the testicle would be able to just flop back and forth in there with the torsion occurring here. You can also have torsion of the appendixes. This is a common cause of acute scrotal pain and may mimic testicular torsion. However, the pain resides quickly. This pain is usually not severe, and they're rarely referred for ultrasound imaging. Pediatric patients with torsed appendix have what's called a blue dot sign, which is a clinical sign. Here on ultrasound, we're going to see an avascular hypoechoic mass adjacent to a normally perfused testis. It may appear as an echogenic extratesticular mass situated between the head of the epididymis and upper pole of the testis. Seen here, testis, epididymis, the structure that's heterogeneous lying adjacent to them without any Doppler flow. Here's the blue dot sign seen in a pediatric patient who then had a torsed appendix testis. This is probably an appendix epididymis because it's hanging out all by itself. Some more blood flow deformities that can occur is a segmental infarction. This occurs after torsion, trauma. It could be a bacterial endocarditis, a vasculitis, leukemia, or different hypercoagulable states. Spontaneous infarction is rare, and this is a non-palpable abnormality. On ultrasound, it really depends on the age of the infarction on whether you're going to appreciate it. Early sonographic appearance may be difficult to distinguish from a testicular neoplasm, but an infarct will decrease in size, whereas characteristically tumors enlarge with time. You are going to see a focal wedged shape or rounded hypoechoic mass within the testis with reduced or absent blood flow. Here we can see how it could be misconstrued as an intertesticular neoplasm, heterogeneous, but you see that round wedge-shaped appearance with no color Doppler flow. Some more pathology, a spermatocele or epididymal cyst. It's a cystic tumor of the epididymis. Spermatoceles are more common than epididymal cysts. These are usually due to a dilated epididymal tubule. They may result from prior infection or trauma. They do contain a serous fluid, and spermatoceles will contain sperm. On ultrasound, both appear similar. They're anechoic, circumscribed masses with no or few internal echoes. Loculations or septations can be seen. Spermatoceles may rarely be hyperechoic, although I've never seen this. Differentiation between the two are not clinically important. Spermatoceles almost always occur within the head of the epididymis, whereas cysts arise throughout the length of the epididymis. Here we can see a spermatocele within the epididymal head. Here is the superior testicle, a sliver of normal epididymal head tissue, and then our spermatocele containing the low-level echoes, which is most likely the sperm. Here on the right, it is more simple. Being within the epididymal head, we would still probably term it a spermatocele, but like I said, differentiation is not important. Another cine that does not work, I'm sorry. Okay, now varicoceles. A varicocele is a collection of abnormally dilated, tortuous, and elongated veins within the pampiniform plexus. They normally range between 0.5 to 2 millimeters in diameter. They rarely are intertesticular, but we have seen those. They are the most common cause for male infertility. This is because of the increased temperature within the scrotum, because of the dilated veins, not allowing the sperm to form correctly. And then there's two types, a primary and secondary. This is supposed to be a cine. This gentleman did have a intertesticular as well as extratesticular varicocele. The primary or idiopathic type is caused by an incompetent valve. You're going to see retrograde flow through the pampiniform plexus with the Valsalva maneuver. Approximately 98% of varicoceles are left-sided due to the venous drainage that we showed you earlier, draining into the left renal vein. You're going to most commonly see this in men between 15 to 25 years old. The pampiniform plexus does normally dilate when upright or when you perform the Valsalva maneuver. You're just going to want to measure in the AP dimension to find out the diameter. We did use 3 millimeters. Greater than 3 millimeters was considered a varicocele. Here at university, our urologists have recently changed that to anything greater than 5 millimeters. The reasoning was anything less than 5 millimeters isn't a surgical candidate. They're not going to do anything for them. This pampiniform plexus may decompress when supine, so you definitely want to perform different maneuvers to demonstrate what you need. And approximately 70% of cases are bilateral. The secondary type is caused by an increased pressure on the spermatic vein. This can range from hydronephrosis, a severe hydronephrosis, hepatomegaly, an abdominal neoplasm, or a retroperitoneal mass. With these, the appearance is not affected by patient position or Valsalva maneuver, so definitely important to do these different techniques. Nutcracker syndrome is also a cause. It's when the SMA, your superior mesenteric artery, compresses the left renal vein. Here we can see a secondary varicocele, a CT on the right showing a retroperitoneal mass. Scrotal ultrasound shows us a varicocele. On ultrasound, you're going to see multiple serpiginous anechoic structures, usually greater than 2 millimeters. Again, here we've recently changed ours to greater than 5. Venous flow may be augmented with the patient upright or during Valsalva maneuver. This is another cine clip showing a dilated pampiniform vein here, measuring greater than the 3 millimeters. No flow with Valsalva. That's what this image was going to show as Valsalva maneuver. No reversal of flow. Now cysts. This is an intertesticular cyst. It's a simple fluid-filled serous structure. They range anywhere between 2 to 18 millimeters, and they originate from the reedy testes. These are usually discovered incidentally on ultrasound in 8 to 10% of the male population. Cystic lesions are not always benign because tumors can undergo a cystic degeneration from hemorrhage or necrosis. Simple testicular cysts can be managed conservatively. They can also form secondary to trauma or inflammatory conditions. Pretty classic cyst. It's round, anechoic. We have through transmission, posterior enhancement. There's epidermoid cysts. They are a benign germ cell tumor. Pretty small percentage, 1%. They are painless, palpable lump within the scrotum, and their walls are composed of a fibrous tissue. Here you can see on ultrasound, it's a well-defined avascular mass. It may be multiple or bilateral, and it typically has what is called a whorled or bullseye target appearance with calcified walls. These benign lesions can be differentiated from premalignant teratomas only through histological examination. An MRI could also be used to help support the diagnosis of an epidermoid cyst if further confirmation is desired. Some other cysts that can form are tunica albuginea cysts. They are located within the tunica layer. So you can see here is our normal testicle. Again, that tunica albuginea provides a support for the testicle itself with this cystic structure arising from it, usually 2 to 30 millimeters in size. They are asymptomatic and can present as a palpable nodule. They can be complex, which could simulate a testicular neoplasm. Here is a tunica vaginalis cyst. They can arise from either parietal or visceral layer. You can see here this is originating from our parietal layer. A second one as well. They can be single or multiple as seen here. They are usually simple, but again, can be complex from hemorrhage. This is tubular ectasia of the reedy testes. This is often mistaken for a neoplasm. Here is the entire normal testicle. This gentleman also has probably a spermatocele, not completely imaged here. This is usually associated with epididymal obstruction, most commonly vasectomy. There is no soft tissue abnormality. This can help you discern from a neoplasm. MRI will give you a definite diagnosis of an abnormal water signal intensity within the mediastinum. An abscess is a complication of epididymal orchitis. It can also occur with an undiagnosed torsion, a gangrenous or infected tumor, or possibly a pyogenic orchitis. Different infectious causes as well. This may rupture the tunica vaginalis, forming the pyocele that we went over earlier, or even a fistula. Clinical findings in these patients will see a fever, scrotal pain, and swelling. Here on ultrasound, we will see an enlarged testicle with a complex fluid-filled mass, increased peripheral blood flow, around the mass, but no internal flow. There are no diagnostic sonographic features of an abscess, just like anywhere else in the body. Abscesses are difficult to diagnose with ultrasound, but we do have some different clues that we can look at with the increased peripheral flow and no flow within the mass. These are distinguished from neoplasms on the basis of clinical symptoms. Here you can see, appears to be a normal testis. We have an enlarged epididymis, the tail. We have this complex structure within the tail. Putting on color Doppler, we see increased peripheral flow. Maybe a little bit, but not much central flow. We can see congenital adrenal hyperplasia within the testicle. It's an autosomal recessive disorder. It brings on precocious puberty with or without salt depletion. And you're going to see testicular mass or an enlargement. And then adrenal rest tumors also arise from an aberrant adrenal cortical cell. It migrates abnormally with the gonadal tissue in the fetus that form tumor-like masses. With these gentlemen, you're going to see an elevated corticotrophin. Here on ultrasound, you're going to see a multifocal hypoechoic lesion. Usually you're going to see posterior acoustic shadowing, and it's going to have a spoke-like vascularity with multiple peripheral vessels on color Doppler flow. Here we can see our adrenal rest. Here's the spoke-like flow. Another tissue migration abnormality would be a splenogonadal fusion. It's rare. It's usually left-sided and associated with cryptorchidism. There are two types, continuous and discontinuous. Not really important for sonography. This is better diagnosed with uptake on a technetium-99 sulfur colloid scan, a nuclear medicine study. So the continuous is where there remains a connection between the main spleen and the gonad, and discontinuous is where ectopic splenic tissue is attached to the gonad, but no connection to the orthotopic spleen. The discontinuous can mimic testicular malignancy. Here we can see the testicle connected to the spleen with the fibrous cord. On ultrasound, here we see a intrascrotal testicular mass. This one is within the testicle itself, both proven to be splenic tissue. Hernias. Scrotal hernia specifically is usually diagnosed on a physical exam. It can contain small bowel, colon, or omentum. Prostrations and peristalsis do help diagnose the colon aspect. You're going to examine the inguinal canal to identify the extension. Only the indirect type will come into the scrotum itself. The direct type goes through a different area. The presence of highly echogenic material within the scrotum may result from a hernia containing omentum or other fatty masses such as lipomas. Hernias usually occur medial-lateral to the spermatic cord, whereas lipomas are lateral or inferior to the cord. Here we can see a sagittal sonogram, testicle. This is the spermatic cord area. we see a highly echogenic structure protruding into the inguinal canal with a Valsalva maneuver. Here on CT, we can see actual small bowel within the scrotum itself. Hematomas, you can have an intratesticular type, which is more common than extratesticular. They are associated with trauma, a ruptured testis. This is often a clinical diagnosis, which is difficult. You'll see marked scrotal pain and swelling. Ultrasound is valuable in assessing the tunica. Prompt diagnosis of a ruptured testicle is crucial because of the direct relationship between early surgical intervention and testicular salvageability. About 90% of ruptured testicles can be saved if the surgery is performed within 72 hours, whereas only 45% can be saved after 72 hours. On ultrasound, a focal area of altered testicular echogenicity will help you find your area of rupture. If you see a visibly intact tunica albuginea, this does exclude rupture. Unfortunately, a hematoma may obscure the tunica, as you see in this image. We see a large hematocele, possibly a disruption here on the posterior lateral side, but definitely obscured by this large hematoma, or hematocele specifically, which occurs in about 33% of testicular ruptures. Diagnosis of rupture based on tunica disruption alone is only about 50%. Heterogeneity of the testis with associated testicular contour irregularity may be helpful in making the diagnosis. Color Doppler may be also useful as well because rupture of the tunica albuginea is almost always associated with disruption of the tunica vasculosa, that most inner layer, and a loss of blood supply to part or all of the testis. Now we'll go over some testicular tumors. These are extratesticular, and adenomatoid is our most common extratesticular neoplasm. It's frequently located in the epididymis, but it can also arise from the spermatic cord or tunical layers. It's generally unilateral, solitary, well-defined, and either round or oval in shape. It occasionally appears plaque-like and poorly defined. Here you can see on ultrasound an extratesticular mass inferior to the left testis within the epididymal tail. And here on the right we see a rather large adenomatoid tumor. Again, benign. Other rare extratesticular tumors are fibromas, hemangiomas, lipomas, leiomyomas, neurofibromas, and the adrenal rest tumors. Sperm granulomas are an extravasation of sperm into the soft tissue surrounding the epididymis. This produces a necrotizing granulomatous response. These are going to be often seen in a post-vasectomy patient. And then fibrous pseudotumors. These are non-neoplastic mass involving the tunica or epididymis. Here on ultrasound is a sperm granuloma. Again, extravasation of the sperm into the soft tissue produces the necrotizing granulomatous response. Here is a small sperm granuloma, testicle or epididymis, This gentleman had a vasectomy. You can see it's enlarged, has what we would term a corduroy appearance, the dilated tubules within it, and then our adjacent granuloma. Non-germ cell neoplasms are going to be your Leydig cell tumor, pretty small amount, 1 to 3% of all testicular neoplasms. This predominantly affects men 20 to 50 years old. This is a painless testicular enlargement. You'll see gynecomastia in 15 to 30% of men. This is from the androgen and estrogen secretion of this tumor. And approximately 10 to 15% of these tumors are malignant. Here on ultrasound, they are usually small, hypoechoic, solid masses with peripheral blood flow on color Doppler. Really, the only way to tell these is a surgical biopsy. Sertoli cell or gonadal stromal tumors, very rare, less than 1% of testicular tumors. There is an equal occurrence across all age groups. This is presenting as a painless testicular mass. Again, we're going to see gynecomastia, especially when this tumor is malignant. There is a large cell calcifying type, which is just a variant. This may occur in an undescended testis or with testicular feminization, such as Klinefelter syndrome. Gonadal stromal tumors arising from the Sertoli or Leydig cells account for about 3 to 6% of the testicular masses, and a majority of these mesenchymal neoplasms are benign. On ultrasound, again, it's going to be a small hypoechoic mass, similar to the Leydig. It can be heterogeneous due to hemorrhage or necrosis. The large cell calcifying type are often bilateral and multifocal and are almost completely calcified. Here on the left is an MRI, and on the right an ultrasound showing these Leydig and Sertoli tumors. Here we see our large cell calcifying variant. Here on the left image, this is artifact, twinkle artifact, or ring down artifact off of the calcification, which we see here on the right. Papillary cystadenomas. These are seen with Hippo-Lindau disease and occur within the epididymal head. It's also called a hamartoma, and these can be malignant or benign. The dermoid cyst can be found intra or extratesticular. These do contain cutaneous appendages, and this is different from a teratoma. So we can see here, cystadenomas sonographically appear as a multiseptated intratesticular lesion. A dermoid appears as a hypoechoic, well-circumscribed mass with no Doppler flow. So you can see here is a tissue, a rim of normal testicular tissue. Some different scrotal calcifications that you might come across with ultrasound. They can be seen within the parenchyma of the testicle, on the surface of the testicle, or freely located in the fluid between the layers of the tunica. The diffuse form is innumerable small hyperechoic foci that are scattered throughout the parenchyma. These are calcifications within the seminiferous tubules. There is a debate on the true association with malignancy. In years past, gentlemen were followed every 6 months or so that had testicular microlithiasis. With more research happening, they don't feel the association is as high as once thought. Microlithiasis is associated with cryptorchidism. This is due to the increased temperature of the testicle. You'll also see this in Down syndrome, men with AIDS, infection, or trauma. An annual ultrasound is recommended with microlithiasis if additional risk factors exist, such as infertility or atrophy of the testicle. Here on the left, we see bilateral microlithiasis. We want to see more than 5 punctate echogenic within one slice of the image. Both of these testicles meet that criteria. Testicle on the right definitely meets that. We can see a diffuse microlithiasis. Scrotal pearls are a fibrinoid loose body arising from the surface of the tunica. This may result from an inflammation of the tunica or torsion of the appendix testis or epididymis. A hydrocele does facilitate the sonographic diagnosis. You're going to see an echogenic mobile structure within the scrotum. Here on ultrasound, histologically, they consist of a fibrinoid material deposited around a center nucleus of hydroxypeptate. You can see here on the left image that central nucleus. This one's building up, going to be a pretty big pearl. On the right-hand side, we can see here multiple pearls within the inferior aspect of the scrotum. You can see how the hydrocele does help facilitate the seeing of these scrotal pearls. Other scrotal calcifications that you might come across is filariasis. It's a parasitic disease. It's caused by mosquito-borne lymphatic-dwelling nematodes, and it's a common tropical parasite with about 120 million people affected in the world, in which 2/3 are in Asia. The male genitalia are frequently involved. Hydroceles are common. You can also see nodules within the lymph system. These are the burnt out nests of the dead adult filariasis. On ultrasound, you'll see what's called a filarial dance sign. It's the microfilia movement within the nest. There is a false positive. My cine doesn't work, but these little echogenic structure within the epididymis dance up and down like so. The false positive would be a megasperm. These are a post-surgical change in vasectomy patients. Because the sperm can't get out, they become abnormal. The sperm get their heads enlarged and they become sticky and glom together to make this megasperm. They are swimming around in there, so that's how you get the false positive for the filarial dance sign. Obviously, you'll use your clinical findings to help decide. On to cancer. Clinical findings, it's a painless unilateral mass. There's several different types: germ cell, stromal cell, metastasis, and lymphoma. These do account for about 1 to 2% of all neoplasms in men. Testicular cancer is the 5th most common cause of death in men from 15 to 35 years old. Approximately 65 to 94% of patients with testicular neoplasms present with painless unilateral masses or a diffuse testicular enlargement, and about 4 to 14% present with symptoms of metastatic disease. Most primary testicular tumors are often germ cell origin and are generally malignant. 60% of one histological type, subtype, and others are of two or more. Seminomas is going to be your most common germ cell tumor, occurring in the 4th to 5th decade of life. This is a less aggressive tumor, usually confined to the tunica albuginea, with a favorable prognosis. Like I said earlier, this is a common cancer found in cryptorchidism, anywhere between 8 to 30%. And this is a common component of the mixed germ cell tumor, which would consist of more than 2 subtypes. Here on ultrasound, you're going to see a round or oval hypoechoic mass, varying size. They can be small or large. They can become necrotic and appear partially cystic as well. Here on ultrasound, this is a rather large one. Mainly is filling the entire right testicle, maybe a little normal tissue here, a normal appearing left testicle. More seminomas. You can see why this gentleman would come with a unilateral testicular enlargement, a large mass within the left testicle, hypoechoic with Doppler flow. Now the non-seminomatous germ cell tumors, also known as the NSGCTs. These are the embryonal carcinomas, teratomas, yolk sac tumors, choriocarcinomas, and the mixed germ cell. This affects men between 20 to 30 years old and are more aggressive. These tend to evade the tunica albuginea and distort the testicular contour. And this is a frequent cause of the visceral metastasis. Mixed germ cell tumors are the most common non-seminomatous germ cell tumor and the second most common testicular malignancy after seminoma. They contain non-seminomatous germ cell elements in various combinations. Seminomatous elements may be present, but do not influence the prognosis. The sonographic appearance of non-seminomatous germ cell tumors reflects the histological features. They are typically more heterogeneous than a seminoma and have both solid and cystic components. Coarse calcifications are common. It is not possible to distinguish the various subtypes of the non-seminomatous germ cell tumors on sonography. Here you can see on ultrasound this heterogeneous mass within the testicle. This left one showing a rim of normal testicular tissue with this more heterogeneous mass. Embryonal carcinoma. This is rare, 2 to 3% of tumors. The yolk sac tumor is the infantile form. This is going to be consisting of 60% of tumors in less than 2-year-olds, so not as rare in pediatric. These are associated with an elevated AFP, alpha fetal protein. And on ultrasound, they're going to be an ill-defined hypoechoic lesion, seen here on the right. Ultrasound appearance is heterogeneous with cystic areas and calcifications with or without shadowing. Teratomas, about 5 to 10% of testicular tumors, They're derived from the 3 germinal layers. The World Health Organization categorizes teratomas into mature, immature, and malignant transformation. They will also have an elevated AFP and HCG, human chorionic gonadotrophin. If this is the case, this is suggestive of a malignancy. On ultrasound, we're going to see a well-defined, complex, heterogeneous mass. They're often dense with echogenic foci. Another non-working cine clip, sorry. Okay, choriocarcinomas. They're our rarest type, less than 0.5%, occurring in men 20 to 30 years old. These are highly malignant. They may have symptoms from hemorrhagic metastasis, such as hemoptysis, hematoemesis. They also can have CNS-related symptoms. Gynecomastia may be seen due to the high levels of the circulating gonadotrophins. On ultrasound, there is an invariable sonographic features. Gonadostromal tumors, 3 to 6% of masses. More common in children, about 20%. They contain single or multiple cell types in various degrees. So the Leydig, Sertoli, thecal, granulosal, lutein cells, and fibroblasts. A gonadобластoma is a stromal tumor in conjunction with a germ cell tumor. On ultrasound, they're going to present with a painless testicular enlargement or palpable mass, seeing gynecomastia in 15 to 30% of patients, with impotence, loss of libido, or a precocious virilization. They're usually small and hypoechoic with peripheral flow. Leydig cells account for a majority of the stromal tumors, about 1 to 3%. About 10 to 15% of those are malignant, and these can undergo hemorrhagic and necrosis, causing them to become heterogeneous. An occult primary tumor. Ultrasound is an important tool for patients that present with mediastinal or retroperitoneal and supraclavicular metastasis from a primary metastatic testicular carcinoma who have a normal physical exam. The detection of an occult primary tumor is important because if it is not removed, metastasis will continue. And they may regress despite the right-spreading advancement of the metastatic disease, so you won't always see a specific mass within the testicle. The regression is caused by high metabolic rate and overgrowing vascular supply. Echogenic focus within or with or without shadowing is indicative of a burnt-out tumor, although it's not specific, but strongly suggests the diagnosis. Here we can see on the right this echogenic area indicative of the burnt-out tumor. Lymphoma. It's the most common secondary testicular neoplasm. It's most commonly bilateral. Testicular involvement occurs in 0.3% of patients with lymphoma, usually the non-Hodgkin's type. True primary lymphoma of the testis has not been documented. They're going to present with a painless testicular enlargement with symptoms of fever, weakness, anorexia, and weight loss. On ultrasound, it's going to be homogeneous and hypoechoic here. It does diffusely replace the testis. And with this tumor, hemorrhage and necrosis are rare. Here on ultrasound, color Doppler imaging shows increased vascularity in testicular lymphoma. It may resemble inflammation in orchitis, but unlike inflammation, lymphoma is painless. Here we have an MRI image showing the lymphoma of the testis. Metastasis is going to be from leukemia or myeloma, usually 60 to 70-year-old men. You're going to see multiple and bilateral tumors, often hypoechoic, but they can be echogenic or complex. Here we see some varying appearances of malignant testicular tumors. On the left, we have a melanoma with color Doppler flow. Here on the right, this gray arrow is pointing to this mass here, which was a prostate metastasis. Just about finishing up here, we have correlative and prior imaging. Nuclear medicine is useful in some different instances. The study of blood circulation in the scrotum using radioactive contrast agent to highlight an obstruction. It's almost exclusively used to differentiate infection of the testis from torsion and infarction. There is a small radiation risk to the reproductive tissue. That's why we'll always start with an ultrasound. Here we can see a nuclear medicine study for testicular torsion. And then finally, CT and MRI. CT is used to determine extent of metastasis. It can also be used for an alternative diagnosis of torsion. There is a higher radiation exposure. With MR, it can help characterize histological type. It is an ideal second line of investigation, and it can reveal unexpected findings. However, sonography is irreplaceable in scrotal imaging. Here we can see some different images. This is a necrotizing fasciitis on the left in the scrotum due to a multiple trauma injury. I'm sorry, this is the necrotizing fasciitis, and then here is the contrast in the scrotum due to a multiple trauma injury leaking from the peritoneum into the scrotum. Here is some more correlative imaging. On the left, we have an abdominal scrotal hernia. And on the right, we have an adenomatoid tumor here on the left testicle. Here's left testicle, so it's an extratesticular mass adenomatoid tumor. To close out here, sonography is a slightly invasive, cost-effective tool. It has easy correlative follow-up. We can also follow treatment changes in different pathological states such as varicocele treatment, chemotherapy, or radiation therapy. Thank you, everyone. Now we're ready for questions.